Okay, so welcome everyone, and thank you for joining us for today's session on frequently asked questions on understanding your labs. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Josh Richter and Ms. Michelle Lin from the Tisch Cancer Institute and Icahn School of Medicine at Mount Sinai in New York City, and also by patient Robert Keane, who is from New Jersey. So they've agreed to answer common questions that patients and their caregivers have about understanding lab results with myeloma. What happened to Josh? Where did he go?
Ooh.
Did we lose him, Heather?
Oh, here he is. He's coming back.
What are you doing? You have to stay. You can't go away.
Apologies.
Okay. Accepted. Okay, so let's see. So we are going to start out talking about bone marrow biopsy tests. So this is one of the first lab tests that myeloma patients will have, is a bone marrow biopsy, but they may not be familiar with what doctors can learn from them. So my first question is to you, Dr. Richter. Can you explain the testing done on bone marrow samples, such as cytogenetic testing? Patients want to know what constitutes high-risk cytogenetic abnormalities, how they occur, and can they change over time, or are people just born with those?
All right, a lot to unpack there. So a bone marrow biopsy is a literal and a figurative pain in the butt. And we apologize, and there's ongoing research looking to get the answer we need outside of a bone marrow biopsy. But at the moment, we gain a lot of information. First off is how many plasma cells are there, how much myeloma is in the bone marrow, 5%, 20%, 90%. And then we start looking for these genetic abnormalities. And these are not genetic abnormalities that you're born with. You didn't inherit them from parents. You don't share them with siblings. You don't pass them on to kids. We're really looking for genetic abnormalities within the cancer cells themselves. And when it comes to the genetic abnormalities, the way to think about it is that we all have 23 pairs of chromosomes, one 23 pair from mom, one 23 pair from dad, so 46 altogether. Each chromosome gets a number, 1 through 23, and each chromosome has a long arm and a short arm. Short arm is P, long arm is Q. So we'll talk about deletions, additions, and translocations. Deletions is where you lose all or part of a chromosome. So you may hear things like a 17p deletion means you are missing part of the short arm of the 17th chromosome in the cancer cells. You may see things like addition, so a gain of 1q, an extra copy of the long arm of the first chromosome, or translocations like translocation 1114, where part of the information on 11 and part on 14 swap some material. When it comes to high risk, this is actually an ever-evolving field. Right now, there's a couple of abnormalities that we consider high risk, and they include things like 17p deletion, gain of 1q, and translocation 414 or translocation 1416. And there's others. Now, this does change over time. And fortunately in myeloma, it just gets worse. You gain more abnormalities, which tends either to keep you with the same risk. So if you gain another genetic abnormality, many of them don't change your risk, but sometimes they do worsen it. So the 1q gain is the most common abnormality that people gain over time. Over time, about 30 to 40% of people will achieve or have a 1q gain. So we can evaluate that on subsequent bone marrows.
Okay, great. So Michelle, how do you help patients prepare for a bone marrow biopsy, which has been described already as being, a pain in the butt? So, and what types of information do you share with them as you, prepare them for this procedure, and, how much it's going to hurt or whatever?
I first let my patients know that this is not a major surgery. It's a procedure that will take the whole procedure takes about 10 to 15 minutes, but you will need to allocate about an hour. Typically you'll go to your provider, you'll get your vitals done. There will be a provider to explain the procedure to you, to sign consent. That takes time. Then you will be either on your stomach or your side, depending on, what your body looks like, depending on your comfort levels. and a provider will give you a local anesthetic to numb the area that they're going to biopsy. Once the anesthesia sets in, they will put a small incision, and then a biopsy needle will be inserted into your bone. And that part of your bone is the posterior part of your pelvis. Dr. Richter has a very funny way of explaining this, like a moose's antler. Do you mind demonstrating that, Josh?
Oh, what?
Yes.
I do not. I mean, sometimes I talk like Bullwinkle. No, I say that if you take your hands like this and then put them on your hip, like, I don't know if you can see on the camera there, like just right on your hip. I'm not trying to moon everybody. Where your thumb rests in the back is where you have the biopsy, but it usually starts off with me looking like antlers.
Yes.
Okay.
The moose antlers. Even with the anesthesia, patients will feel a pressure, and that pressure is uncomfortable. I would say it's more anxiety provoking more than anything. I would say, and Bob can confirm this for me, when the proceduralist is actually pulling the aspirate, the marrow part of your bone marrow, that is probably the most uncomfortable. Although it is quick, it is uncomfortable. We can typically give medications to offset the anxiety, pain medications. We will work with patients on this. Once the procedure is completed, proceduralists will apply some pressure, bandage to your skin. They'll take your vitals after you're done, making sure that everything's okay and there's no excessive bleeding, and then you'll get to go home. And typically bandages are removed 24 to 48 hours after the procedure.
Okay. I actually don't ever remember someone telling me in such detail exactly what this entails. So, I mean, it doesn't sound as bad as some people sort of make it sound. And Bob, as a patient, I know that you've had several of these, and you didn't really seem to find them that bothersome, right? So can you share some of what your experience was like with the bone marrow biopsy?
Well, first, I had Michelle to explain it. The first one I did. I didn't. My original oncologist was rather, you need a bone marrow, and we started the process.
Wow.
But listen, I've had about 6 of them now, and I would agree they're not painful, a little uncomfortable, but I think just right about the fact if you get stressed out about it, it's probably worse. But if you just lay there and let it happen, they're pretty quick. I said that was my first one. I mean, after that. They can, as you need them, you need them. It's not been a lot. I mean, some oncologists do it themselves. Some people have a whole, group to do that more regularly. So I think you could, not that you can feel the difference, but there is differences in who does it. Some people have a easy hand. Some people have a heavy hand. But either way.
Yeah, I mean, I can see that.
Either way, it's done pretty quickly, and like I said, it's all about information as far as I'm concerned.
Yeah.
Whenever it's needed, it's needed.
Right.
It's just part of what we do to give the teams here as much information as they can to help us.
Yeah. So, I mean, I think that, for now, this is really some of the best way to get some of the best information about what's happening with your myeloma. I think that in the future, as we develop more tests and more expertise and more sensitive ways of measuring things, then potentially bone marrow biopsy might sort of go by the wayside. Although I'm sure that patients are still going to have some of them at some point, right? So right now, we have to use bone marrow biopsy to assess minimal residual disease, or MRD, especially in the clinical trial setting. So Dr. Richter, can you describe what MRD tells us about a patient's myeloma and why not all clinics may measure it?
Sure. So as our technology gets better and better and better, we're able to kill more and more myeloma, and not just our treatment techniques get better, but our diagnostic treatments get better. And really, this is all about the zero line. How low can we detect myeloma? If you go back in time to the first person to ever officially be diagnosed with myeloma, Sarah Newberry, in the 1840s, we didn't have all of this fancy technology. We didn't have next generation sequencing and flow cytometry. So 0 for her was when they didn't see a mass of myeloma. Then we got microscopes, and we got flow cytometry and molecular studies. And right now, the best technology we have, we call MRD, MRD. Some people call it minimal residual disease. Others call it measurable residual disease. They're basically competing technologies to find 1 in a million or 1 in 10 million cancer cells in the bone marrow. And essentially what we know in general is that the deeper remission you get, the better. So if you took 100 people and matched them age, sex, disease, everything, and this group got MRD negative and this didn't, the one that gets MRD negative tends to stay in remission longer. But that's not the end all be all. There are people that never get MRD negative and can stay in remission forever. And part of the reason why not a lot of, or not all places are doing it is that it's an amazing technology. The FDA recently voted 12-0 to incorporate it in terms of getting drugs to market quicker by using it in clinical trials. But we haven't all agreed about how to use it in the clinic. So that's why a lot of the doctors have not embraced it fully, is that it's a good tool, it's a powerful tool, but it's still kind of like, 2001: A Space Odyssey, when that monolith lands. It's impressive, it's shiny, but at least for myself, I'm just shaking bones at it.
Yeah. It's funny that you talk about, what does the M mean in MRD, right? So there's actually a guy at ASCO just this past week who did a presentation on MRD, and he actually made it a voting question, right? So does the M stand for minimal? Does it stand for measurable, or does it stand for molecular? Right. So he wanted to sort of standardize this in the field. And he said, this is the best place to ask that question. But then I don't even know how the voting went. So I don't know what people voted for. So I guess we'll find out one of these days. So we'll see. I don't know. So Michelle, can there be times when the biopsy doesn't give enough information, or somehow there's not enough cells that are removed from the bone marrow to be able to test things appropriately? And so when that happens, what does that mean for patients?
That is a really good question. And it does happen from time to time, not always, but it does cause so much stress for our patients. And it can happen for so many reasons. Either the technique, the bone is too soft, there's crushed artifacts, or, just the marrow might not be so great. We might not get a good sample. We try not to, do so many biopsies because, they're traumatic and they're really uncomfortable and painful for patients. But what we have to ask is, what were we doing with these tests? What exactly were we looking for? Were we looking to confirm diagnosis? As we know, criteria factor for diagnosing myeloma, one of them is CRAB. Were we already able to confirm diagnosis? Maybe we didn't get everything, like the exact percentage of plasma cells, but if we know on the PET scan, the patient has lytic disease that are clearly myeloma, we have enough information to get the treatment going. And then, were we able to see anemia in the lab? Were we able to see hypercalcemia? We might not have a small portion of the information, but we have enough to move forward. Yeah. So that's something that we can work with. The other thing is that sometimes we're doing these marrows to see if we can find a genetic, some sort of genetic information. We'll send out testing information for FISH. And sometimes we don't get enough plasma cell to test for this. However, that does not mean your provider cannot treat you. We need FISH to get risk information for a patient's myeloma. However, Dr. Richter can see in the span of 1 year, say you are a smoldering myeloma, but your markers are going up by 2 to 3 times, like every 2 months. We see that your anemia is getting worse by the minute. We know that your disease is now behaving aggressively. So even though we might not have the genetic risk, we can still determine how your disease is also going to, respond. And also, the way that patient's disease responds to treatment can also tell us about your myeloma, the risk analysis of the patient's myeloma. What else did I wanted to say? Dr. Richter, what else do you think we need? What else do we do with these tests? Like if we don't get them, what else would you say to the patients?
The question is, how much do we really need the information? If if we have someone that we really, really need it, sometimes we'll repeat the bone marrow. But I think what Michelle said is absolutely perfect, is that bone marrow gives us good information, but most of the time we don't need to repeat a bone marrow to make the decision. If you had a bone marrow a year ago and we found myeloma there and we decided that, we didn't think you need treatment, and over the next course of the year, things changed in the blood, we don't have to repeat it to treat you. But in terms of, one of the questions I think you were alluding to, Mary, is when we do MRD testing, we do need a certain number of cells to say that it's MRD negative or positive. So, normally we want at least, depending upon which technology you use, you have to look at somewhere between at least 2 and 5 million cells, because you can take an extreme version of that. If you took out one cell and that wasn't myeloma, is that enough to say that you're really MRD negative with enough resolution? And the answer is no. So depending upon which technology, usually we need at least 2 to 5 million. But I've had patients come in where instead of 5 million, we got 4 million and they were all negative. To me, that has a big meaning in and of itself. And that's always a good sign.
I will jump into that. My first 2 bone marrows, they found no myeloma cells in it. And yet we knew, based on the blood tests and based on some other issues talk about it, basically we started treatment almost immediately. Not waiting for any. They had enough information, even though the marrow didn't come back with what they wanted, for us not to proceed.
I mean, luckily for myeloma patients, there's a lot of other biomarkers that indicate disease other than like counting the number of cells that are in the bone, especially because it's, these things can be rather patchy, right? You can have like a bunch of myeloma cells over here and then like no myeloma cells over here. And depending on where the needle goes in, either you're going to get some or you're not, right?
So we say it's like Swiss cheese. Sometimes you get cheese and sometimes you get
I think I got more holes than cheese. I don't know.
I like that. Okay.
I got to the point. Do we want to use the left hip or the right hip? I think the right hip had better cells in it last time.
Should we say that it's a cheesier hip?
Cheesier hip? Nice.
Yes.
Like that. Good. Okay, so now we're going to move on and we're going to talk a little bit about blood tests. So this is another staple of myeloma management, lots of blood tests, and there are many things that the care team can learn from blood tests. So patients in our last webinar that we had that talked about learning labs had several questions about monoclonal protein. Monoclonal protein is also called M protein or M spike and is measured using serum protein electrophoresis or SPEP. Right? So Dr. Richter, can you tell patients what the M spike value tells you, as well as some of the other components of these SPEP results, like the alpha and the beta and the gamma globulin?
Sure. So all of the proteins in the body fall into 2 categories, albumin and globulins. Albumin is like the white of an egg, and kind of as a general rule, higher albumin is good and lower albumin is bad. Then all the other proteins in the body are globulins, and there's different types. There's alpha 1, alpha 2, beta, and gamma. Gamma globulins are where antibody proteins live. And normally when we look at a patient's blood, we want to find a polyclonal group of gamma globulins. Poly meaning many, meaning we want to see your body making antibodies to fight flu, COVID, shingles, all of the different infections. But when you have one group of bad cells that are all making the same bad protein, because it's one, we call that monoclonal, and we see a spike of that one bad protein. And in general, we make assumptions that a certain amount of M spike, bad protein, tells us that there's a certain amount of myeloma in the bone marrow. It's not always a one-to-one, meaning we can have people that have a lot of M spike, but only a little myeloma in their body. We call that hypersecretory, makes a lot of protein. Or you can have a very low M spike and a lot of myeloma in the body. We call that hyposecretory. There's even non-secretory where the myeloma cells don't make any of it. But at the end of the day, what this really means is that we have some number, and when we treat you, if that number goes down, we know that that went down because the cell that made it got killed by our treatment and went away. And then when we see that M spike come up, we say, we think that there's myeloma growing and we need to either switch or adjust the treatment you're on.
Right. Okay. Makes perfect sense. Okay. So, Michelle, can you explain the parts of the Comprehensive Metabolic Panel, or the CMP test, that are important to monitor when managing myeloma, and why are they important to monitor?
So when we're looking at the CMP, we're looking to get a broad assessment of patients' physical health and the extent of their myeloma. The CMP, there's about 14 to 16 measurements, depending on how you want to group them together. That includes kidney function, electrolytes, albumin, liver function. I think we should talk about 3 different parts that are most pertinent to patients with myeloma. We can talk about the kidney function, which can be explained by creatinine, which is a muscle byproduct produced by your body, with eGFR, which is an estimated glomerular filtration rate. We typically can see that, with elevated creatinine, there are high levels of damage to your kidney by your myeloma proteins. The creatinine is not only telling us what myeloma has done to a patient's kidney, but it's also important in terms of patient staging. Your providers are going to use this information to choose a therapy that works for your patients, and also that's not going to be further toxic to your patient's kidney. The next part of your chemistry that we're also going to look at very carefully is calcium. Active myeloma can cause damage to your bones because there's an increase in your osteoclastic activity. We know this because a lot of patients present with bone fractures, spinal compression, and back pain. We know that elevated calcium is very dangerous in terms of cardiac issues. It can cause GI issues. But this is also important for staging. So we're going to be looking very carefully into that. And also total protein. And now there's total protein and there's also albumin. We actually look at both. We look at the total protein because it's going to give us an idea. Say we don't have the markers of how bad or how high your myeloma markers are going to be. Even without having IgG, all of that, we can kind of get an idea of this. And then we're also going to look at your albumin. Albumin is a type of protein that transports substance in your blood, and it's also a very important indicator of health. We can see low albumin typically in patients that are a lot older and doesn't have a good nutritional status. This is also important because it also helps us with staging. Lower levels can also indicate different types of disease. And, we're going to look at all of this to help us with staging and also guiding us in terms of treatment.
Mm-hmm. Mm-hmm. Yeah, that's interesting. So I remember when my mom was diagnosed with myeloma, it was because she had this, she was acting very, very strangely. And my father didn't know what to make of it. And it turns out that her calcium levels were like through the roof. And that's how she was really diagnosed with that, right? So, and that can happen. So,
yep. So, from a community setting, it's actually really interesting you said that. Say someone's going for their annual physical with their primary physician, and their primary physician will run a comprehensive panel, and they'll see, nothing is that bad. Maybe touch of anemia, maybe mild renal impairment, but their total protein is elevated, and that should automatically trigger them to order a myeloma panel. And if it's abnormal, they should send them, probably a referral to us or another hematology oncologist. So we see a lot of patients that way by, another provider examining the comprehensive metabolic panel.
Yeah. So, and this happened before I was working with the MMRF, and I didn't know anything about myeloma at the time. But if it was now, I'd be like, oh, high calcium. It's a hallmark. Okay, so Bob, you have what we thought was a very practical approach to interpreting your lab results, right? You said you don't get too worked up over specific values, but you focus more on the trends of the values, whether things are going up or things are coming down over time, right? So can you explain a little bit more to the patients who are listening, what that mindset, how that helps you thinking about things that way?
Well, first of all, listening to Dr. Richter and Michelle, I'm glad I went to business school and not medical school. So This just proves you have to have the right team behind you and let them worry about all the little markers.
Agree. Totally agree.
I mean,
Thank you.
This is why I have a financial, person who does things with my money, because I could not be less interested in that.
Well, I said I do trust the team. They do explain things to me, and if I do look at them, I do like the trends, because the software that they use and we use gives you the ability to chart a trend.
Yeah.
So even if you don't know what the number should be, you can see if it goes up or down. Of course, we all track the M spike, because that's kind of the that's kind of the telltale we use. But other than that, some of the others I'll just use kind of a trend analysis. They do a very good job of explaining it, and so I don't need to dig any deeper.
Mm-hmm.
I think it just, again, we talked about, you have to have a lot of confidence in your team.
Yeah. True.
If you have, the more confidence you have in the team, the less you're worried about the minutia. That's their job.
Let them worry about that.
Yeah, but I want to give a compliment to Mr. Keane, because I think one of the things that he demonstrates in spades is being your own advocate. I think that one of those things that he does tremendously well is, yes, he'll follow our instructions, but he is always, he's asking good questions. He's advocating for himself. So I think he's a great example of that.
So that's great. And that's what I think is so useful about this type of format for really showing relationships between care teams and their patients, right? And I think that many patients sort of need to see that there should be a lot of communication between patients and their care teams. And that's like very, very helpful on both sides of that coin, right?
I mean, and the blood test to me is like a security blanket. I like having them done. I like the labs. It gives us all a way to track what's happening. So, I mean, I can't imagine going through this without having the labs available to look at and be able to discuss.
Yeah. People usually say that myeloma patients are very lucky because there's a lot that can be told about their cancer from these lab tests, right? There's a lot of biomarkers that can help track. And, the M spike is a perfect example of that, because it's just a blood test, right? And it's not horribly invasive, right? But it does tell you a lot about what's happening with your cancer. So, which is important. Okay, so Dr. Richter, patients often wonder if advances in blood tests may one day be able to substitute for bone marrow biopsies. I think we talked about that a little bit before. So, for example, there's been data published recently on using peripheral blood to measure minimal residual disease. Is that something that might make a bone marrow biopsy unnecessary one of these days?
So, and I think this is kind of the brass ring of myeloma. We're trying to figure out how to answer two big things in the blood without having to do a bone marrow. One is how much disease is there, a little or not, a lot or none, and what are the cytogenetic features, high risk or any what we call targetable genetic abnormalities, because some of those abnormalities we can use specific drugs for. The difficulty with peripheral blood is that it doesn't always represent what's going on. One of the things that Mr. Keane pointed out was there were several times where we did scans and saw that he had myeloma, but the bone marrows themselves wouldn't show much in there. So there's not, we don't have the correlates yet to say if you have a level 5 in the blood, it equals 50% in the bone marrow. So we don't have that just yet. The other thing that we know about myeloma, and I'm going to throw out a crazy term, spatial genomic heterogeneity. And I'll explain what that craziness is that we know that myeloma in different compartments of the body may have different genetic properties and different genetic drivers. So the disease that survived and made it out into the blood may be very different than what is still left behind in the bone marrow. And we don't yet know that it's going to be the exact same thing. So there are a lot of efforts right now to figure out both of these answers in the blood, but we're not quite there just yet.
Yeah. So, and so, I mean, I think that we will eventually get there as time goes on, but, it'll be interesting to see how that sort of evolves, right? And that sort of being able to see, like you were saying, the different cytogenetic abnormalities in different spatial areas, which is basically related to which clone is like sort of living in that spot and proliferating there. So, Michelle, patients are curious about interpreting the kappa and the lambda light chain results. So how are these light chains measured? And what do patients need to know about their kappa and lambda light chains and the ratio of those two things?
This is a really good question. And there's about 8 ways of interpreting this, depending on how you want to cut the cheese, the Swiss cheese, that is. I'm going to start out with this. I'm going to ask patients not to compare the light chains and their light chain ratio with another patient, because everybody's myeloma is very different. Everyone's kidney function's different, and everyone's getting different treatments, and they're in different cycles of treatment. And I'm going to talk about a couple scenarios where, hopefully this makes sense to patients. Free light chain tests can show whether your myeloma is creating too many lambda or kappa light chain. So say you're a smoldering myeloma, you have smoldering myeloma, or you have MGUS, and you have your myeloma makes too much kappa proteins. So it's going up. We know your ratio is going to, be off. We know that. You do the test again 2 months. It's slightly higher. It's going up. However, the question to ask is, what are these light chains doing to your body? Are you having issues from these light chains? Are you having those crab symptoms that we talk about? The hypercalcemia, the anemia? Is it causing damage to your kidneys? Are there damage to your bones? So those are the key questions that we always ask in the case of MGUS or smoldering myeloma. So that's one thing. So the other thing you have to ask is, where are you in terms of your treatment? Are you actually progressing? Is your kappa light chain just going up and we need to change therapy? That can be the case. However, are you a patient with kidney dysfunction? Are you on dialysis? Because those numbers, your lambda light chain, your kappa light chain, they're both going to be high. And we're going to be paying really close attention to your kappa lambda ratio, because the light chains are going to be off just because of the kidney dysfunction. The other scenario that I want to talk about is sometimes with successful therapy, we've actually suppressed all of your light chains. So your ratio is going to be low, your kappa light chain is going to be low, your lambda light chain is going to be low. So that can happen. So I want to say to patients that it could be absolutely abnormal, but I would reach out to your provider to interpret this, because everyone's disease just behaves so differently, and your provider probably have to walk you through it a couple times. I'm sure Mr. Keane is really savvy at interpreting his results, because he's one of our savviest patients.
Okay. All right. That makes perfect sense. Okay. So now we're going to talk, now that we've gone through blood tests, now we're going to move on to imaging, right? Which is another lab test that people have all the time. So Dr. Richter, what is the recommended time for PET scans to be done? And what do PET scans tell you?
Sure. So there's no exact recommendation of when they all need to be done, because every patient's going to be different. We commonly do one at diagnosis to find out the extent of things. And oftentimes do it if you do a transplant 3 months after. And then in general, most patients will have them something like once a year, though there are alternatives like MRIs that can be done, or other CAT scans. Patients that we can't follow their disease in the blood, that non-secretory disease, patients that have no M spike, we may do them more frequently. But a PET scan is a really cool scan because it offers two things. It offers what I call an anatomy scan and a functional component. An anatomy scan is like a CAT scan. It slices you up and you look at heart, lungs, liver, kidneys. And then the example I always use is, let's say I'm really difficult in clinic and Michelle gets so fed up with me, she kills me. Now, if you were to kill me and put me in a CAT scanner, the CAT scanner was still going to show you brain, lungs, liver, kidneys, but it doesn't tell you alive or dead. And the same thing can happen with myeloma and other cancers, that sometimes there can be cancer that can be killed and it'll leave scar tissue. It won't be alive, but it'll still show up as an abnormal mass on a CAT scan. The way that PET scans help us is you take in a radioactive sugar, and all cells in the body use sugar as part of their daily activity. The more active a cell is, the more sugar it takes up, and the brighter it will glow. So the more active or more myeloma you have in certain areas, the brighter it will glow. So sometimes our PET scans in the beginning will show lesions that are very, very bright. We use a term called the SUV, the standard uptake value. So you may see an abnormality in the bone that has an SUV of 11, and then we treat you, and that lesion is still there on CAT scan, but the SUV is now 2, which means we've actually killed it and it's back down to the baseline. So it gives us a lot of information.
Interesting. I always see those pictures, right, with the bright, it looks like a sun, right? Some like bright yellow thing there, right?
Well, the sun is always your brain. The brain always glows bright. Mine doesn't, but many people, the brain will glow bright.
That's where all the metabolic activity is there, right? Yeah. So nice. Okay, so Michelle, can you tell patients listening what they should expect during a PET scan? How do patients prepare for that? What does it entail, and how long does that test take?
The test itself takes about 15 to 20 minutes, I would say. The whole process, I want to say, takes about an hour because of the wait time. And, you will have to either get a contrast via IV or by mouth. Typically, you'll go to your nuclear medicine center and, check in, and they'll either give you something to drink or they'll give you something through your IV. You'll wait about 20 to 30 minutes, and then you'll be in a kind of like a donut-like machine for about 15 to 20 minutes. You will be exposed to a little bit of radiation, but not a lot. It's okay. So your provider will typically work with you to say, maybe they'll go between a PET scan and an MRI just to reduce your radiation risk. One thing I want to note with our patients is that sometimes, patients want to live a very healthy lifestyle and they will do a lot of workout before. Don't do that, because there will be findings on your muscles, and they'll ask me, Michelle, there's all these things lighting up in my muscles. What is this? I was like, well, did you go to the gym by any chance? Were you lifting a lot of weights? Try not to do that before your next scan. The other thing I try to tell my patients is reduce your carb or sugar intake before, because if your blood glucose is too high, you might not be able to perform those scans that day, and it's a pain in the neck to reschedule. Those are the things I usually tell my patients, and that's really about it. It's a really non-invasive procedure.
That's super interesting. I never really thought about it that way, right? That, what you want is the uptake of the dye. So you have to make sure that there's not other glucose in there that's blocking everything.
Yep.
Or, your muscles are so hungry because you just worked out like crazy that all the uptake goes into there because it's glucose, right? Yep. That is pretty funny. I never thought about that. So, Bob, you said findings from an MRI that you had for back pain was one of the early indicators of your myeloma. And I think that's really a pretty common way that many people get diagnosed with myeloma is from back pain. So what imaging tests have you had since you've been diagnosed?
Well, just to go back to that, I've always had a back problem. So one of the last, right when I was diagnosed, was probably the worst back problem I've ever had. So did an MRI with the specialist, and he was as surprised as I was when he said, well, it's not back pain you have a myeloma lesion on your lower back. So that's kind of was our introduction into going into for a follow-up with the myeloma. But after that, I had, again, multiple PET scans, and I think everyone said is right. They're not overly invasive. They take a little bit of time. The key is get a morning appointment, because you have to fast anyway. So don't want something in the afternoon. So I always got my PET scans done 9, 10 o'clock in the morning. That's just practical. As a businessman, I'm practical. I want to get it done. The worst part is you can't have coffee, Don't let them sugarcoat that. No coffee. And I've never tripped a TSA when I go to the airport, so I guess it gets out of your system pretty quickly. But it's me. It's all about information, and the more information everybody can have, the better the final outcome is. Yeah,
that's true. Very true. Okay, so where are we? Okay, so we're getting towards the end here. So we're going to move on to some final thoughts here. So Dr. Richter, what about patients with precursor conditions like smoldering myeloma and MGUS? So what tests should those folks have, and how often do they need to have them? I suppose they probably need to have them more often if they have like a high risk form of those precursor conditions.
Yeah, I mean, I think there's, the terms MGUS and smoldering are very firm terms, and biology doesn't like firm terms. We could say that if you have 9% in your bone marrow, your MGUS, and 11% your myeloma, your body does not know or care whether or not you're 2% different. We do a similar workup that we do whether or not you have myeloma, MGUS, or smoldering. We do blood work, a bone marrow, and an imaging test like a PET scan. If you have smoldering myeloma, we oftentimes recommend blood work every 3 to 4 months and some type of imaging at least once a year. And it's important because, Michelle mentioned those crab symptoms. The first 3 you can see on blood work, but B, you can only see with imaging. So we do recommend some type of imaging at least once a year. For MGUS, we usually recommend checking blood work every 6 to 12 months. And we don't even necessarily repeat blood work. Remember that MGUS is a very common and oftentimes benign thing that happens with age. So if you come in with an M spike of 0.1, do we need to do a bone marrow biopsy and a PET scan every year? No. If a year has gone by and your M spike's still 0.1 and you have no other symptoms, we frequently don't even repeat imaging because the likelihood of developing trouble is so low. And in fact, now it's really wonderful. The Icelandic group actually has a calculator that you can go online, it's free, plug in your numbers, and it'll tell us what's the likelihood, given those numbers, of finding myeloma versus MGUS in the bone marrow, and helps us decide should we do a bone marrow or not if you have such low level disease.
That's very interesting. These Iceland people. What they got there? They're testing everybody in that country, right, for myeloma.
Yeah. So they have this wonderful test. I think it's everyone over the age of 40 or 45. It's a very homogenous group, so their data is probably a little bit less applicable to people of Hispanic or African American descent. But what's really helpful about this data is that once they draw the blood work screening people, they group them into 3 categories. And group 1 gets bone marrows, PET scans, MRIs, the whole 9 yards. Group 2 gets regular blood work, and group 3 doesn't get told that they found a monoclonal gammopathy, and they wait for them to show up in the Icelandic medical system with a full-blown cancer. Now, I don't think that would fly very well in the US, but we are learning a lot about the natural history of these disorders.
Yeah, which is useful, right? So it's useful for everyone. So that's good. So Michelle, what is the typical frequency for having like these blood tests and bone marrow biopsies and imaging studies? And does that frequency change during different stages of myeloma? So for example, when patients are undergoing treatment versus when they're in remission, and what about when a patient relapses?
It's a really good question. So when patients are undergoing treatment, they will have CBC, comprehensive metabolic panel, every single time they are at our facility. Myeloma markers are not done every day or every week because we should be monitoring them a little bit further apart, about 3 to 4 weeks. As far as imaging, we typically have that done already. However, if the patient presented with, say, a lot of lytic disease and we see that the markers have gone down, we will repeat a imaging study within a certain time to make sure that their lytic disease has also gotten better. If symptoms have gotten worse, we will also order another imaging just to make sure that patients are not progressing and have not developed a new lytic lesion. If patients are in remission, that's a very good question. Say patient has undergone transplant, and we know that they're in remission and they're on some sort of maintenance therapy like Revlimid. We won't often complete a bone marrow biopsy unless it's absolutely necessary, unless there's something that we're looking for. We will complete imaging studies. Depending on, what's going on, if they're actually, are they having pain? If there's new symptoms that warrants imaging, Dr. Richter and I will definitely order imaging. However, if they're serologically in remission, they don't have any bone pain, they don't have hypercalcemia, maybe we'll do imaging once a year, and we can work with the patient on that. And then you said, what about after a patient relapses? Well, are we necessarily going to order a PET scan bone marrow? Depends. Where is their disease? Are they a patient with lots of paraproteins, or are they a patient with just findings on, PET scan? Do they just present with lytic disease? And that really changes the type of test that we order, because not everyone is going to have the set bone marrow and the PET scan every single time. Some people, they don't produce the protein, so we actually have to image them about every 3 to 6 months, depending on what's going on. I want to talk to you about another type of case that, Dr. Richter and I run into. Typically, our patients, they've gone through multiple lines of therapy. Their markers are, perfect. Their PET scan's perfect. However, they develop new onset anemia. Their platelets are down, and we don't really know why. We'll order a bone marrow biopsy to make sure we're not missing secondary malignancy. Then that's something that we have to do.
Yeah, that makes sense. So, Bob, I know that you've completed a clinical trial, right? And you recently started on a standard treatment. So how often are you currently having all of these tests, like the blood draws, bone marrow biopsies, and imaging done?
Well, I guess to end the clinical and to start the standard treatment, I've had both the bone marrow biopsy and also a PET scan just the last couple of weeks. Currently, my new protocol will be weekly for about 8 weeks, as I understand it, and then possibly then going bi-weekly, and then eventually, hopefully, monthly. That's kind of I think that's the process that we're shooting for. So weekly now, it's all labs every week. So that's usually the first thing we do is do labs, and then we start the infusion process. I mean, again, to me, it's information. The more information everybody has, the better off, we are talking about it and following up. So, I have no problem doing all of this. I think I called it a security blanket earlier, and I really believe that these are, they help me understand, and I help the team understand what's going on.
Yeah. So what is the therapy that you're going to be starting? Is it a bispecific antibody?
Dr. Richter, I'm the accountant, not you. I'm the accountant, doctor.
So he's starting DKD, so daratumumab, carfilzomib, and dexamethasone, the standard of care version of the Candor trial.
Right, got it. Okay.
I knew that.
Oh, okay, good. Okay, so Dr. Richter, can you describe for patients how the results of these various lab tests that we've discussed translate into having a treatment response, specifically regarding terms that patients may hear, like complete response, partial response, MRD negative, etc.?
All right, so we have two different evaluations. We have standard responses and MRD responses. And a lot of people think, well, MRD means you're already below complete remission. And it turns out you can be MRD positive or negative, and a standard response, partial remission, complete remission, you can be all the different varieties. And the best way to think about it is CAR T has been really an amazing new therapy, and CAR T kills myeloma cells very quickly. But that M spike has a half-life of about a month. It floats around in the system even after the cell is dead. So you can imagine if we did a CAR T on someone, and a month later we did a bone marrow, the bone marrow could be MRD negative. All the cells are gone, but the protein is still circulating in the blood, and they may only be what we call a partial remission. So the terms we use are, if your M spike doesn't go up or down by 25%, we call that stable disease in either direction. More than 25% up, we call that PD, or progressive disease. 25 to 49% down, we call that an MR, or minor remission. 50 to 89%, we call that a PR, or partial remission. And then the really crazy term VGPR, a very good partial remission, 90 to 99%. And then if we want to talk about complete remission, we have to go into the bone marrow. And a complete remission is fewer than 5% plasma cells and no M spike. And then there's actually something called a stringent complete remission, which is no plasma cells. And also not just no M spike, but your kappa lambda ratio has to be normal.
Which is 1, right?
So it's interesting. It depends upon the lab. A normal capital lambda ratio is somewhere between 1 and 2, but it can even go a little bit below because you can have more lambda than kappa. So think about 0.5 to 2, give or take. But the Icelandic people also just presented in a paper in December that as we get older, the normal kappa will go up and the ratio will go up so that people over the age of 70 can have a normal kappa up to about 50 and a normal ratio up to almost 4.
Wow.
Yeah.
Interesting. Okay, so one final question as a follow-up to that. So patients have these tests and the values can go up or down as you were talking about, but it isn't always concerning to their care team. So, Dr. Richter, what findings among these various tests would raise a red flag to you that the treatment isn't working and that some kind of change might be needed?
So I think one of the things that has been talked about here today is this is a disease of numbers, and there's a ton of numbers that come flooding into my chart. You have 2 tubes of blood drawn, and you get 50 numbers that fly into your portal. And sometimes normal is abnormal, and sometimes abnormal is normal. And what I mean by that is your hemoglobin can go from 17 to 12. Both of those numbers will be normal, but that's a 5-gram drop. And if we saw that, we would be worried that your myeloma is getting worse. You can have an M spike that goes from 0.2 to 0.4. That's a doubling of your M spike, and that's of no concern. You can get a difference in your left arm and right arm bigger than that. So really, it's all about the context. I think Michelle pointed it out expertly that there are some changes that we expect. There's some that we don't. So at the end of the day, I'm not even going to give you a straightforward answer because patients need to talk to their care teams because big changes could be nothing if it's a flare from a medicine. Big drops can be nothing. So it gets very complicated very fast.
Yeah, and everybody's disease is different, right? So it's sometimes it can be very difficult to generalize about these things. So okay, so we're almost at the top of the hour here. So on behalf of the MMRF, I'd like to thank Dr. Richter and Michelle Lin and Bob Keane for their time and for joining us today and discussing all of these important questions. I'd like to thank everyone who's watching for taking their time out of their day to watch this presentation. Finally, I'd like to thank our sponsors, AbbVie, Adaptive, Baxter, BMS, Cure, Genentech, Kite, Arcellx, Pfizer, Regeneron, and Sanofi for their sponsorship of this session. If you have additional questions about what you have heard today on this live stream, please don't hesitate to call our MMRF Patient Navigation Center. Their number is 1-888-841-6673. So thanks, and that concludes our broadcast for today. Bye.
Thank you.
Thank you.
Take care.